This lesson is on ischemic stroke. Let's talk about the pathophysiology of an ischemic stroke, which is a medical emergency. Now, this can be due from a thrombus or an embolism. A thrombus is going to form in the cerebral artery. An embolus is going to move from a different part of the body, usually the heart. Either way, you're going to have that abrupt alteration in perfusion. We're not going to be delivering oxygenated blood. So look at my picture on the right. We're going to have an area of ischemia. Now, when this area of ischemia happens, you're going to have cell breakdown and cell death, which is what causes cerebral edema and further dysfunction in our patient. Let's talk about the risk factors of an ischemic stroke. Now, if we're talking about a thrombotic stroke, or a clot that forms in the cerebral artery, this is going to be from anything that causes atherosclerosis, so hypertension, diabetes, hyperlipidemia, or smoking. If we're talking about an embolic stroke, there are three main reasons that a clot will move from a different area of the body to the brain. You can have carotid artery disease, so you're thinking of atherosclerosis in the carotid artery. You can have atrial fibrillation, so your atria are fibrillating. That can cause a clot, and if our patient goes into sinus rhythm, that clot will move straight to the brain. You can also have abnormal cardiac valves from infective endocarditis. Now, this is from vegetation or material that grows on the valve and then will break off, moving to the brain. Let's talk about a trans-ischemic attack, also called a TIA. Now, this is considered angina of a brain attack. It is a warning sign of a stroke. Typically, a TIA is going to be localized, which means it's going to resolve quickly. So those neurological deficits like weakness or changes in speech, those only last a few minutes to a few hours. Because a TIA resolves, it's never detected in imaging. Our patient is fully functional within 24 hours of the TIA. Let's talk about the clinical features of an ischemic stroke. Your best bet is to remember the mnemonic, be fast. B is for balance. Your patient can have ataxia, meaning an unsteady gait, or vertigo, so they're going to be dizzy, making them a fall risk. For eyes, we're thinking blurry vision, diplopia, or double vision, or they might have visual field deficits that we'll talk about in another slide. Their face is going to be weak, drooping, and they may experience numbness, usually on one side. For their arms and legs, they're also going to have extremity numbness or weakness. Look at the picture on the right. Our patient is experiencing pronator drift, so when they put their arms out, hold them evenly, one arm will start to drift slowly down. Your patient might have speech or swallowing deficits. Now, they could have aphasia, where maybe they can't understand or even make language, versus dysarthria, which is a weakness in the speech muscles. Finally, your patient can have dysphagia, meaning they could aspirate from a weak swallow. All this wraps up to time. Knowing the onset of symptoms of a stroke is going to be very important for the healthcare provider to help us treat. Let's talk about the clinical features of hemispheres of the brain. Now, keep in mind when your patient has a stroke in the left hemisphere, this is going to affect their analytical thought, things like language, reading, reasoning, math and sciences, versus the right hemisphere, which is the artistic part of the brain. So emotion, art, music. Now, no matter which hemisphere is affected, know that a stroke in one hemisphere always leads to weakness in the other side. Let's talk about the diagnostics involved in ischemic stroke. The gold standard is going to be a CT of the brain without contrast. What the physicians are doing are ruling out a hemorrhage so they can treat the stroke with TPA. You'll see some other tests too, and that's going to depend on etiology of an embolic stroke. So if I have carotid artery atherosclerosis, maybe I'll see an ultrasound of my carotid artery. If my patient's in AFib, maybe I'll see an ECG. Versus if I have infective endocarditis, I'm going to have an echocardiogram to look for vegetation. Let's talk about the nursing interventions involved in ischemic stroke. Again, we have to determine that time of symptom onset, and this is because physicians cannot give TPA or thrombolytic therapy unless it's been under 4.5 hours. We're also going to assess for contraindications regarding TPA. Is the patient actively bleeding? Have they had a recent brain or spinal surgery? Remember, there's only so much room in our cranial vault that can lead to cerebral edema. We have to make sure that we control their hypertension because if we give TPA, we don't want this to turn into a hemorrhagic stroke from high pressure and thin blood. If our patient has low platelets or a high PT-INR, maybe they're taking Coumadin, we also couldn't give them TPA because they would hemorrhage. Once our patient has TPA, we're going to monitor them in the ICU. Remember, our patient just got a clot buster. They could bleed. We're also going to do frequent neuroassessments and vital signs, and this will be dictated by your facility how often. We also have to look for signs of increased intracranial pressure, so I'm thinking unilateral pupils or maybe even Cushing's triad. Now, if your patient didn't get TPA, we're going to allow for permissive hypertension. What does that mean? When you think about an ischemic stroke, think of that ischemic core, that area of damage that you see in the brain. When we allow our patients to have a higher pressure for 24 hours, we are hyperperfusing, meaning we're sending a ton of blood and oxygen to that area, trying to save the tissue around the ischemic core. This way, our patients will have better outcomes and better brain function. Let's talk about the nursing interventions for an ischemic stroke in the acute stage, meaning the first day or two. We're going to have to monitor our patient's neurological status, so I'm thinking cranial nerves. The speech therapist is going to perform a bedside swallow assessment. Remember, our patient can have dysphagia, and they can aspirate their secretions, which is why suction is needed and should be hooked up in the room. We're going to keep that head of bed elevated because we want venous drainage from the brain to reduce cerebral edema. And we have to remember positioning. We need to turn our patient to that unaffected side with their head positioned midline, neck neutral. And make sure that we're doing passive or active range of motion exercises. We don't want them to become more debilitated. We also need to prevent future complications. So doing these passive and active range of motion exercises will reduce contractures. Keeping them moving will stop constipation. We don't want these guys to have any impacted stool push down and further elevate their intracranial pressure. Also, moving them will keep them from having pressure ulcers. And a day or two after TPA, we have to start thinking about DVT prophylaxis. So I'm thinking of drugs like enoxaparin, keeping them safe from what? Another blood clot. Let's look at even more nursing interventions for an ischemic stroke. Let's talk about aphasia. So again, our patients can't completely communicate whether they're trying to talk to us or even understand us. This is why it's so important to face the client, establish eye contact, and we're going to make sure that they can focus. So turn that TV off, let them focus with us. Try not to speak loudly or shout with them. You're going to have some patience with these patients. Allow them time to respond. Ask simple yes or no questions, and if none of that works, we can use things like hand gestures, imaging, or the patients can even point on communication boards. Let's talk about hemi-neglect and hemianopsia. When your patient has a stroke, that affected side with deficits, they may ignore. So you have to have the client touch and see and recognize that side of the body. You're going to ask them to move their head and actually look at that affected side, that side they're not looking at and they're ignoring. We also want to approach them from their unaffected side. We don't want to scare our patients, and we also want to make sure their personal belongings, like their meal tray, is in front of them so they can see it to actually eat. Let's talk about nursing interventions for that chronic management of an ischemic stroke. So patients that are homegoing, rehab, getting discharged. We want to address the main reason for an ischemic stroke, which is what? You got it, atherosclerosis. This is why our patients are going to get blood thinners, statins. We're going to control their blood pressure and make sure that they stop smoking if they are, because it causes sticky, thick blood. We also want to make sure our patient is having physical activity or exercise, and usually case management will set up some kind of rehabilitation program for them at discharge.